Good morning. I'm Laura Harmon. I don't know if I know all of you. I'm the Trauma Medical Director here at Boulder Community Health. Thank you so much for coming to our party. We have some really great speakers today, and really an opportunity for me to show you all of the amazing people here at Boulder Community Health. So thank you, Dr. Goldman. Next up is Dr. Gross. Dr. Gross is board certified in orthopedic surgery and orthopedic trauma. He joined Boulder Center for the Orthopedics in 2022 and very rapidly became our orthopedic trauma medical director for Boulder Community Health. Last night I was working on my bios for all of our speakers and Googled Dr. Gross. There's a Dr. Gross somewhere in the Northeast that likes to fish. Do you like to fish? Not this one. But I did find out that this Dr. Gross, besides being an amazing surgeon and just really an asset to our program and great leader, is also a musician. So maybe when he's done talking about bones, he'll tell you a little bit about music.
Good morning. Happy to see everybody. Thanks, Laura, for inviting me to talk today. I'm going to make sure I can get this thing figured out. Which one's the laser? This one? Okay. Cool. Great. I'm going to step a little bit off to the side so I can kind of keep an eye on what I'm doing over here, too. So thanks to Dr. Goldman for a fantastic talk. I think that he and I were talking before the conference started, and what I didn't get to tell him was I actually seriously considered going into ENT in medical school, and so this is a fun talk to have me listen to. And I think that the pelvis, much like the face, is a little bit of a black box. There's a lot of facets and nuances to it that aren't necessarily apparent, and so I think this is a good topic to cover, especially with us getting into summer trauma season. We're going to start seeing pelvic fractures a little bit more regularly as the energy of the injuries that people sustain starts to increase again. So I'm going to be talking primarily about what we do with pelvic fractures, how we identify them, and how we manage them in the initial phase, which is probably going to be relevant, I think, to most people in the audience. So let's see how we do here. So my goals for this presentation, I'm going to spend a little bit of time talking about anatomy, kind of open up that black box a bit and try to help everyone understand a little bit more about what's going on inside the pelvis, and also explain a bit about fracture pathology. Of course, we want to talk about optimizing the early management of these injuries. And also, at the end, we'll provide a little bit of insight to talking about how we fix the patients. So we'll start simple. At its most basic form, the pelvis is made up of 3 bones. There's the sacrum, which is the base of the spine and lies posteriorly, and then there's 2 innominate bones, which form the 2 halves of the pelvis. And innominate literally means not named. And that's because the bone is kind of a weird shape. It doesn't necessarily have a name unto itself aside from just the bone that's not named. And then the other landmarks in the pelvis, we have the 2 sacroiliac joints, which join the sacrum to the iliums, which are the part of the innominate bones. There's the pubic symphysis, which is the midline in the front where the 2 innominate bones join. And then the acetabulum, which is the name for the hip socket, and we got 2 of those too. So this diagram kind of illustrates a bit of the different regions of the innominate bone. So we have the ilium, the ischium, and the pubis. Those are the 3 regions of the innominate bone. And the pubis is broken down into 3 different regions: the pubic root, which forms a little portion of the acetabulum and the very beginning of the ramus; pubic ramus, which is that bar of bone that runs in the middle of it; and then the pubic body, which is the midline portion of the pubis that forms the pubic symphysis with the opposite side. There's not going to be a test on this. The purpose of this slide is really just to kind of show, we can kind of look at the bones and look at an X-ray or even a CAT scan and say, okay, yeah, that's the pelvis right there. But there's so much going on the inside, right? This is a super complicated area with a lot of really high-priced real estate running through it. A lot of really important nerve structures, vascular structures, and visceral structures as well that run through the area. And so when pelvic trauma occurs, as nasty as an X-ray might look, what a lot of times the major concern is actually what's going on that can't be seen on the x-ray, and this is just an example of all the stuff that can run through there. I'm going to spend a little bit of time just kind of going through this. This is the venous anatomy, and we'll talk more later why this is so relevant, but there's a tremendous amount of vein activity that runs through the sacrum, around the sacrum and in the posterior part of the pelvis. We have the inferior vena cava that branches off to all the different vessels, and there's a super highly complex venous plexus that runs through this area. So pelvic fractures, as I think many people are aware, are dangerous. They can be dangerous. Not all are, but many are. And they can be life-threatening injuries. And as with many things in orthopedics, there's two general populations that get fractures, pelvic fractures. There's high-energy trauma, which can happen in any age group. And then low-energy fragility fractures, which we typically see in people who are in the elderly demographic, but could technically occur in anybody who has any kind of impaired bone density issues. And there's two overall categories of injury to the pelvis. There's the pelvic ring, and then there's the acetabulum. And so these are two x-rays that kind of show the difference between that. So a pelvic ring injury is when the general structure of the pelvis, the innominate bones and the sacrum become disrupted, and that general shape gets altered. And that's on the left, and the x-ray on the right, we see an injury of the acetabulum, right, which is an injury to the hip socket, a fracture of the hip socket itself. And so acetabulum fractures, which are near and dear to my heart, and while serious and complex injuries, are unlikely in isolation to result in any kind of major hemodynamic problems. There's a low risk of acute decompensation. They're often difficult, especially in the field, to distinguish clinically from other hip or proximal femur injuries. And there's nothing really that's quote-unquote special, right, that we need to worry about from an EMS perspective or even initially in the ER. The caveat there is that a lot of times a patient with an acetabulum fracture, before we even know they have an acetabulum fracture, they're going to meet criteria for thinking about a pelvic ring injury in the field. And then once x-rays are obtained, of course, we'll get some more clarity on what's going on. So pelvic ring injuries, though, by contrast, are among the most potentially lethal bony injuries that exist in the trauma domain. There's a propensity towards internal hemorrhage, and these patients can rapidly decompensate. And so the focus of this talk is going to be to kind of narrow in on pelvic ring injuries. That's going to really help us kind of distill what's really important for these people. So talking about the pelvic ring, so true to its name, the pelvis functions like a ring. It's mechanically very strong. For any engineers in the audience, a circle or a ring is a very mechanically strong structure. It resists force very well. And so the pelvis is very, very good at resisting force in general until, of course, it breaks. And so generally speaking, when we talk about a ring, rings typically have to break in two places if they're going to break. And so a pelvic ring injury is typically going to break in two or more distinct locations in the pelvis. If you want to imagine just taking like a circular pretzel type thing and you try to break it, you're going to have a really difficult time breaking it in just one spot if you try to break it. And the pelvis is the same way. So typically when we look at a pelvis x-ray, if someone looks at a pelvis x-ray and they see maybe an obvious injury in just one area of the pelvis, it would be very unusual for there to not be a second one somewhere else that maybe isn't seen quite as well on an x-ray. And a CAT scan will, of course, pick that up a bit more readily. So in the pelvis, injuries can be bony, purely bony, where just the bones break and the ligaments and the joints don't separate. They can be ligamentous or a combination of the two. In this image on the left here, we have widening. Arrows are helpful here too. We have widening and disruption of the sacroiliac joint right there, and then widening of the symphysis pubis right there. And then for the injury on the right, we have a fracture cutting through the pubic body right here, and then some ligamentous disruption as well. And so all these structures can be in play when someone gets a pelvic ring injury. So this is the basis for how we describe pelvic ring trauma. This is a representation of what's called the Young and Burgess pelvic trauma classification system. And so there's these different categories that come about, and they're named by the kind of impact that happens to the pelvis when the trauma occurs. So what we typically call an open book pelvic injury is actually an anterior-posterior compression injury. So typically this is going to be an impact from the front of the pelvis, kind of directly from front to back. And this causes the pelvis to open up. And so from types 1 to type 3, we see increasing amount of severity of the injury and increasing amount of displacement. There's also something called a lateral compression injury, which is where the force comes from the side. Typically, this is from an impact that hits first the upper part of the femur, and the femoral head becomes like a pile driver that pistons itself into the pelvis, and that causes the pelvis to compress itself inward. And then vertical shear, which is more typically from a fall from height, someone landing on their foot, and the force drives the limb force up into the pelvis and then shears the pelvis vertically. And then what's not listed here, but is also often in play, is the combined mechanism, where it's more than just one pure kind of vector of force. So I think from a practical perspective, when we look at these injuries in the ER, we get x-rays, we get CAT scans, there's two basic categories though. There's the volume expanding ones and the volume compressing ones. So things that tend to cause the pelvis to open up or create more volume are in a bit of a different category from the lateral compression ones that actually close the pelvic volume down. And there's different considerations, especially for the volume expanding ones that we'll get into. So the volume expanding ones are typically much more life-threatening. Statistically speaking, there's a much higher incidence of vascular injury. There's way more room for blood to accumulate in the pelvis when it's opened up and there's more volume on the inside. And they're not necessarily higher energy though. It all has to do with how the energy is acting on the pelvis, right? So you can have a super high energy lateral compression injury that can be devastating to the patient, but it's maybe less likely to cause internal hemorrhage and rapid death, as opposed to maybe a slightly lower energy open book pelvic trauma. So high energy pelvic injuries, we're all pretty familiar with what can cause these, but MVAs, MCAs, pedestrians struck by motor vehicles, falls from height. Classically, as with many high energy injuries, these often occur in a younger patient population, but any age can sustain high energy trauma, and this is a really important point, right? So we often think about kind of little cracks in the pelvis being from an elderly person who fell, but someone who's in the older age group can also be in a car accident, and they can also have really significant pelvic trauma that can happen. And then, of course, the higher energy injuries often have associated injuries as well, such as, for example, a Lafort fracture, like that one patient. We can anticipate that pelvic trauma may accompany any blunt high energy injury mechanism, and this is important, right? So in the field, or when someone rolls into the trauma bay, if there's been a blunt high energy impact to a patient, we have to assume that there is the possibility of pelvic trauma. And distracting injuries may be present, so the patient may not necessarily localize pain to the pelvis. Associated injuries that we often see, we see chest trauma, hemothorax, pneumothorax, that type of thing. Head injury is super common, especially with the lateral compression injuries. Long bone fractures are common as well. Spine injuries, and then visceral organ injury, and the liver and the spleen are often implicated with people who have pelvic trauma. So by contrast, low energy pelvic injuries, this is our classic kind of trip over a rug, or the dog knocked somebody over, they fell in a parking lot and landed on the side of their hip, and then they have a pelvic fracture on the x-rays. And so typically this is a fragility fracture found in those with low bone density, and the most common demographic there will be the elderly patient. Frequently these occur in isolation, so we don't usually see a lot of associated trauma with these, although it certainly can happen. And usually it's a lateral compression pattern. So this is someone who falls on the side of their hip, and the femur just kind of crunches the pelvis inward. And in someone with normal bone density, this would not be expected to cause a fracture. In someone with some weaker bones, that can be what happens. And this is X-ray kind of shows that a little bit. It's subtle, but so there's like a little crack right there in the front of the ramus there near the pubic root, or near the pubic body, and then usually the sacrum has a little crunch in it as well. So some low-energy pelvic fractures can be unstable enough to warrant surgery, though often in this patient population, when we do surgery, it's not necessarily because it's super unstable. We do it because it makes them feel better, helps them get up and walk faster. But life-threatening hemorrhage or hemodynamic instability is really pretty uncommon because there's just not enough energy to impart to the pelvic structures that causes disruption of them in any meaningful way. So with that introduction behind us, we can kind of get onto some kind of clinical side of stuff, right? What we need to do for these people. So the goals of care in someone who has a pelvic fracture, right? We want to first identify it because it isn't always readily apparent that someone has an unstable pelvic fracture. We want to control hemorrhage and stabilize any kind of bleeding that's going on internally. Resuscitation is, of course, important. Stabilize other injuries and then move on to definitive management of the patient. So as I mentioned earlier, it's really important to consider the mechanism, right? If there's a high energy blunt trauma, we got to think about the possibility of there being a pelvic ring injury. Subjectively speaking, about 2/3 of patients with unstable pelvic fractures will report pelvic pain. And so that seems like, okay, that's pretty good, that's over half, but that also means that 1/3 of all patients with an unstable pelvic fracture will not report pain around their pelvis in the field or in the ER initially, right? So we have to have a really high index of suspicion. And this probably the same third of patients are the same people that probably aren't even going to report pain when you examine them there. You could push on it, poke on it, pull on it, and they're not even going to say they hurt. And I've definitely seen patients who have horrible looking x-rays and who say, oh, I don't really hurt that much there at all. I mean, it's pretty impressive sometimes that people somehow don't feel pain there. Direct manipulation of the pelvis is to assess for instability, right, which would be our thought, like how can we have an objective measure to figure this out? Well, this is also unreliable. There's been some studies shown on actually examining the pelvis and how the inter-observer reliability is actually pretty poor when it comes to examining the pelvis in general. So it's not necessarily a reliable indicator. And in general, when someone's out in the field, EMS is involved picking up these patients, we don't really want to be putting our hands on someone's pelvis and rocking and rolling it around to see just how unstable it is. It's not really the best thing to do to somebody. But even in the ER, we're going to probably check it, and that's going to be part of the C for circulation portion of the primary survey. That will typically be where someone will put their hands on the pelvis and just check it to see how unstable or if it is unstable. So exam findings to look for, right? So there could be bruising, and this is a big indicator, right? Bruising around the pelvis, around the genitalia in particular, is often a good sign that there's something wrong going on in there. Looking for rectal, urethral, or vaginal bleeding is very important because if there is any of that and there's pelvic trauma present, that's basically an open fracture until proven otherwise, and that's a very important thing to note. Any kind of deformity of the pelvis would, of course, be a solid indicator, but what's more common than that is a rotational lower extremity deformity. So a lot of times people will come in, they'll have an open book pelvis, for example, and the legs will just be opened out, they'll be frogged open. You'll look at that and be like, that looks really kind of funky. That doesn't look like someone's leg should be rotated in that direction. And the first thought usually is, oh, they must have broken femurs or something like that, but it actually often is a broken pelvis when that happens. Or, for example, a limb length discrepancy in someone with the vertical shear injury where half the pelvis is shoved upwards towards the rib cage. The legs will look like they're a different length. And in general, an unresponsive victim. So if someone's unconscious, they can't tell you what's going on, and they've had a high energy mechanism, we should probably assume they have a pelvic fracture. That's a good thing to bet on, because even if you're wrong, it's better to bet wrong in the field and protect the pelvis than it is to bet wrong and they actually have one. So this is how a pelvic exam is done with respect to the pelvic ring. So there's two modes. There's the compression and there's the distraction. So for compression, we have the hands on the outside of the greater trochanters of the femur and the outer part of the pelvis, and then kind of pushing inward to see if the pelvis moves inward. For distraction, the thumbs there are right within that recess medial to the anterior superior iliac spines, kind of right there inside of the hip pointers, and then kind of trying to basically open the pelvis up like a book. So I wanted to spend a little bit of time here. This is a great picture here, this diagram that I found online. So the pelvis, thankfully the pelvis is a symmetric structure, at least it should be in most people, right? And so we have the benefit of being able to compare one side to the other when we look at how things are supposed to look. And there's a few things to key in on. The first thing I'll mention in this x-ray is that the spinous processes are in the midline of the vertebral bodies. That's probably the most important thing that we need to start with, because if someone is crooked on the x-ray table or on the x-ray beam is coming through them, the pelvis is going to look crooked too. So as long as we have a decent midline lumbar spine, anterior posterior view here, we know that when we're looking at the pelvis, it should be symmetric as well. So the things we're going to look at, we're going to look at the sacroiliac joints. We're going to look at the ring. This is the ring, right? So we're going to look and see, is it symmetric? Is there any irregularity or incongruity from side to side? We can look at the obturator foramen as well and look for the same thing. There's this thing called the Shenton's line, which you can see right here, and that just refers to the general curvature of following that curvature of the femoral neck to the obturator foramen there, and just making sure that it looks like it matches up. Looking at the iliac wings, the acetabulum, the iliac spines, all these things are really important things to look at, because fractures can occur in any of these areas. And so this is an example of, we've looked at this x-ray a couple times, but where this has been disrupted. And so the part that's obvious, right, is where the arrows are pointing, but there's some other subtle features too, and this may be hard to pick up because of the shading, but this iliac wing is externally rotated compared to this iliac wing. There's more of it. You can see more of it. It's kicked out a little bit. There's also, this is really hard to see, but the ischial spine, which is this triangular structure right here, is way more visible here than it is over here. And so in the absence of something obvious like arrows pointing at something like that, those are keys that we can look at. So moving on to our next goal of care, we want to talk about controlling hemorrhage. So any significant pelvic trauma will result in at least some internal bleeding. Right? And the problem is that an unstable open book pelvic ring injury in particular allows for so much more volume of blood to accumulate. So this is a horrible looking x-ray, right? This is a life-threatening injury that this patient has sustained. And so we're looking at this and we say, okay, yeah, the pelvis is opened up in the front, but you see the pelvis is actually opened up in the back as well. There's been a lot of tension that's occurred there. And so this venous plexus that we looked at earlier has just had this happen to it, right? So there's been this huge tension for it that's come across, and it's basically started to rip these vessels wide open. And the same thing can happen to the arteries, right? But the veins have the weaker walls. The veins are much more sensitive to this type of thing. And the pelvis can hold over 4 liters of blood in it, and that's even without it opening up. So you can imagine if we have a pelvis that's opened up, a patient can get their entire circulating blood volume dumped into the pelvis without too much time going by. So one of the initial goals for hemorrhage control in a pelvic ring injury is to normalize the pelvic volume, close that space down, and then perform vascular intervention if needed. So we want to turn something like this into something like this. And that's going to make it a lot better for this patient to survive and have a much better chance at that happening. So in order to accomplish that, we have these, our friends, the pelvic binders, right? Many of us have probably seen these things before, and we're going to talk a bit about kind of how these things work and why they're important. So for a pelvic binder, right, the goal of a binder is to decrease the pelvic volume and normalize it, right? And I'm going to hammer this point home like maybe 50 times over the next 5 minutes. The application should be centered over the greater trochanters of the femur, right? So even though it's called the pelvic binder, it's actually functioning by driving the heads of the femurs inward and using that to cause the pelvic volume to close down. I know this is not a pelvic binder that we would put on a patient in the ER, but I have this slide up here to show how it's not supposed to look, but how it often does when it's applied. So we can see that the belly button's totally invisible here. The greater trochanters are down here, right, the widest part of the hips, and this thing is centered kind of more over to the iliac wings, right? So this is not how this is supposed to look. We want this to be moved downward and kind of more over the greater trochanters. And so we should be able to see the umbilicus, right? If we can't see the belly button when a binder is on, it means it's been placed too high. So this is an x-ray. We can see our little circles for the T-pod here, and we can see the bottom of the circles are kind of like right around here, right? So this binder is centered directly over the iliac wings, and we ideally want that center to be down here. It's not that it doesn't help, because it can help. The problem is that in a lot of people, they may actually have some cracks going through the iliac wing as well, and it's not a very reliable place to put the binder. You really want to try to be lower. And it's important, because putting the binder on correctly can truly save somebody's life. So, steps to applying the binder. We're going to want to expose the patient. That's pretty typical. We're going to be doing that anyway in the trauma bay. We don't want to be putting the binder on over a bunch of clothes. Slide the binder under the hips while avoiding rolling the patient. So log rolling the patient with an unstable pelvis can cause a lot of sloshing around, and it can disrupt a lot of clot in the pelvis. And so we want to try to find a way to get that binder underneath them, underneath the butt area, without having to roll them around. We want to ensure the center of the binder is centered at the greater trochanters of the femurs. And then internally rotating the lower extremities can be a really helpful thing. So as I mentioned, a lot of these patients are gonna look like their legs are rotated out. And in surgery, anyone who's kind of seen me position a patient for surgery, this kind of thing, I take the legs and I rotate them inward, and I duct tape the feet together, and I hold them inward like this before I prep and drape them for surgery, because just doing that alone usually gets you halfway there at least. And so rotating those legs inward will help drive the pelvis together, and then once you've done that, you can cinch down the binder. And don't be shy, because it's very difficult to hurt a patient by cinching down a binder, and it only usually is helpful to them by tightening it. So this is a video, and we'll see if we can get this to play, that I will kind of narrate, and this just kind of shows the application steps, and it's a kind of a useful thing to see kind of how to do this. So, we have a patient, right? They're going to be down to skin level, right? We're not necessarily totally naked, but we want to get the bulky clothing off. And then we're going to slide the binder underneath those hollows in the knee. You can also go behind the lumbar spine potentially if there's access there. And then we're avoiding log rolling here. Again, this is a really great picture of where those greater trochanters are. Kind of go to that widest part of the hips, right? And then we're gonna aim for that area. Move on here. So kind of lift the butt a little bit up, right? Not log rolling, but just kind of vertically lifting them up in the air. And then we get the binder going across. And again, we're over the trochanters here, and then cinching it down. This is a really powerful thing, right? As long as the femurs aren't broken, and even if they are, it doesn't matter, you can still do it. But if they assume that there's some integrity there, the femoral heads are incredibly good at pushing the pelvis inward. So that's how that looks there. So what if there's no binder? And I've done this myself on a handful of occasions. So you don't need a binder. If you don't have a binder, you can use a sheet. The one thing I want to highlight in case anyone ever does end up doing this is that this is really important. There's no knot in the sheet. These are clamps. And so what I think is the intuitive thing that people think is they're going to take the sheet, wrap it around the pelvis, kind of pull it really tight and tie it like a bow, right? That makes a lot of sense. It made sense to me when I was first starting out in orthopedics, and then I was told not to do that. So it doesn't work very well because you lose a lot of that tension on the sheet when you're trying to tie a knot in it. And so what works best is kind of a three-person job. You can imagine having the sheet wrapped around, one going this way, one end going this way, and people kind of just pulling really hard. It's kind of a three-person job. One person pulling this way, one person pulling this way, and then a third person comes in with clamps, just clamps down the sheet ends to each other. That's how you're going to actually keep the tension on the sheet correctly. And I've actually done surgery through a sheet. Sometimes I've had pelvic ring injuries that are so unstable that I take off a sheet or a binder and the pelvis goes into a different zip code. You can put a sheet on there and just dump betadine all over it and cut holes in the sheet and use that to put screws and plates through. So it's a really useful tool, especially if the binder is not gonna work for whatever reason, or if there's not one available. So moving on to endovascular intervention, right? So this is our secondary measure after the binder's on. So angioembolization, right, is going to interventional radiology and using catheter-based intervention to stop bleeding. And this is a really safe and effective method to control arterial bleeding, right, from arteries. The problem, of course, is that, as we talked about, the venous system is often in play and usually the much bigger culprit when it comes to bleeding inside the pelvis. So the veins aren't really able to be readily targeted by this method. But for the arteries, it's a great method. The complications are relatively low, and when they do occur, they're certainly preferable to ongoing hemorrhage and death. So we're going to think about sending someone to IR to get embolization done if there's a contrast blush seen on CT. These arrows are kind of pointing to small areas of blush. In addition to the presence of blush, there are some risk factors that are associated with benefiting from embolization. These include large hematomas, an elderly patient who has a higher energy mechanism, and of course a widely displaced pelvic ring injury is going to be at higher risk of needing embolization versus one that hasn't gone out of place very far. So let's talk about REBOA. This is a little bit different, right? So REBOA, REBOA is an acronym. It stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. So this is what this thing looks like. This is the kind of thing you don't want to have to utilize very often, but when you want to use it, it's really good to know what it is. So this catheter gets fed up into the artery, into the femoral arteries, and snaked up into the aorta. And it basically functions as the same thing as if you crack somebody's chest and cross-clamp the aorta. It basically totally blocks the aortic blood flow. And there's different zones to the aorta. There's zone 1, which is everything from the kind of the takeoffs of the subclavians from the descending aortic arch down to kind of the mesenteric zone. There's zone 2, which is where the mesenteric arteries are and the renal arteries, and then zone 3 is below that. And so this balloon can be placed and can be inflated in different areas depending on what's needed. And so, generally speaking, these are the indications for REBOA, and these are actually quotes from our pelvic fracture protocol that we have here at BCH. So if someone has a pelvic fracture, they have a binder on, they're being resuscitated, and they're still crumping, they're still doing very poorly because of ongoing hemorrhage, we can consider putting the REBOA in zone 3, which is basically below the abdominal stuff takes off, but above where the vessels go into the pelvis. And so this basically cuts off all blood flow to the pelvis and the lower extremities when the REBOA is put up there. Of course, it's going to be a temporary thing. And then a zone 1, which would be higher up, would be in the setting of massive intra-abdominal hemorrhage in association with a pelvic fracture. That's going to be where there's a lot of bleeding into the abdominal area, and we need to stop the bleeding into the area. And generally speaking, if someone has a REBOA put up, their next stop is the operating room, because this is meant to be a temporary thing. Obviously, this cannot stay up for any significant length of time because there's going to be pretty significant problems to the lower half of the body if there's no blood going to it. And so the OR is the next stop for these people. All right, so we've controlled hemorrhage, and now moving on to resuscitation. And usually this is an ongoing thing that's happening at the same time that hemorrhage control is occurring. We're all kind of familiar with the idea of resuscitation, right? We're giving fluids, we're giving blood products. And so for fluids, we're talking about crystalloid infusion. Dr. Sovendal at this conference last year gave a really great talk that talked a bit about permissive hypotension, right? About allowing these people, as long as they're safe enough to tolerate it, having their systolic blood pressure be a little bit low. And that's allowed as long as this patient is awake, they're able to converse with us, they're making adequate urine, they're not showing any signs of any end organ hypoperfusion, right? Because if we're diluting these patients' blood volumes with crystalloid, all we're doing is giving them lower and lower and lower blood counts, right? We're just making them watered down, and that's not necessarily a good thing at all. The contraindications to this permissive hypotension approach, though, are basically a central nervous system insults. So we have a brain injury or a spinal cord injury. And then, of course, is blood product replacement, which is going to form a very important mainstay of resuscitation for a patient that's having a lot of internal hemorrhage, right? And that's certainly what pelvic ring injuries can have. So we're going to utilize our massive transfusion protocol. We're going to give blood products in a 1-to-1-to-1 ratio for the platelets, the FFP, and the packed red blood cells. So in terms of stabilizing other injuries, pretty straightforward, right? Once we get through our life-threatening needs, we're going to look at everything else. It's pretty common for someone with a pelvic ring injury to have other injuries, including the orthopedic injuries, right? We're going to splint, we're going to brace things. People are maybe going to get chest tubes placed for chest trauma, and other things like that. But usually the pelvis, if there's a big unstable pelvic fracture, usually the focus first needs to be on getting that situation figured out, and then everything else will happen as well. Admitting the patient to the hospital generally occurs once we have our initial efforts completed. And in terms of criteria for ICU admission, anybody with that's unstable hemodynamically, obviously that makes sense, and they may have other metabolic problems going on a laboratory basis. Anyone who's gone to IR or gone to the OR for hemorrhage control really needs to be in an ICU bed, because that intervention may have been successful, but then things may change. Any kind of vascular compromise to the extremities would, of course, qualify here. And then really anybody, even if they're clinically stable, if they have an unstable pelvic fracture that requires a binder or something along those lines, they really should be in the ICU, because I have personally seen people look good for a couple hours with a pelvic injury, and then suddenly they start to go bad fast. So close monitoring is very important. So, and after all this, then we think about definitive management, right? So, and this is what I do. So, this is a patient who came into our ER a little bit over a year ago, actually. This is his injury, AP pelvis, and this is a, I think this X-ray really kind of belies just how severe this was. I'm not sure exactly. Maybe this is just a good moment for the X-ray to be taken. But when I took the binder off this patient in the OR, his pelvis probably opened up 5 times wider than it looks like right now. And unfortunately, the X-ray tech deleted the C-arm image that I saved, so I can't put it up there. But so this is an open book pelvic injury, and there's widening of the symphysis pubis. Here we can really see what I talked about with that ischial spine before. Right here, this kind of pointed part of the bone is way more visible here than it is over here. And we can see that the iliac wing is way more kind of in profile. It's wider out than this one is. And so we know that the right side of the pelvis is opening up. It's externally rotating. There's some irregularity of the sacroiliac joint over here. There's a shadow running through the sacrum. So it's hard to see like what's going on with the sacrum here, right? And this is really typical for an AP pelvis. Maybe there's something going on there. We can assume, right, because we know the pelvis always breaks in 2 places, that if there's an injury in the front, there's got to be an injury in the back somewhere. And so we know that something's not quite right. So we look at this 3D rendering of this patient's CT scan, and we can see this is actually a really complicated sacrum injury. It's a really rare pattern. It's an L shape, so it kind of cuts down like this and then heads horizontally across like that. And then this was taken with the binder on, so we can see that that's almost, you can call it almost overcompressed, right? Because normally the pelvis wouldn't be totally closed down like that, but that's fine. That's great for this patient, right? This is a life-saving thing that he has on here with this binder. And so when we're talking about restoring the pelvic ring, the general goals, surgically speaking, are, well, we have a break in 2 places. It's usually nice to put instrumentation in 2 places too, right? And so we want to take care of the front and the back. And so that's what happened to this guy. This was an X-ray that was taken about a month after surgery, actually. So he ends up with a few plates and a whole bunch of screws holding everything together. And at least for this patient, I have the benefit of long-term follow-up on him. I just recently saw him for his 1-year follow-up. He actually has no pain in his pelvis and walks around without any crutches, cane, or a limp or anything like that. Actually, one of his biggest issues came about more from the injuries higher up in his chest and abdominal area that continue to give him problems. But pelvic-wise, he's actually doing rather well. So thanks a lot for your attention. Appreciate your time, and I'm happy to answer any questions.
Can you repeat questions into your microphone so they can get it remotely when folks ask you questions?
Sounds great. Yeah, go ahead.
When you put a binder on to help control injuries, etc., how does that help control bleeding?
Yeah, that's a great question. So the question was, how does the binder itself help control bleeding? And so, yeah, venous in particular, right? So there's 2 main mechanisms for it. The first is kind of closing down that pelvic volume, which means there's less blood that can get into the pelvis, right? So that's helpful right there, just because there's going to be an outflow restriction to the internal hemorrhage. But what it actually does is it's kind of like a splint for the pelvis, so it stabilizes clot. and I didn't really talk a lot about that, but it's a very good point. There's a mantra in orthopedic pelvic trauma, which is the first clot is the best clot, okay? And so we don't want to have a binder coming off and on, because every time that happens, the internal clot is being disrupted and the bleeding starts again. But when we stabilize it and hold it together, the bleeding in the pelvis will clot off, and that will actually help stem the flow of the bleeding that's ongoing in the area. So those are the two ways that the binder helps. Yeah. Yeah, so the question is about where the center of the binder, the top of the binder, where it sits. It really depends on how wide your binder is, but the center of the binder should be over the greater trochanters, right? That way you can even have like a narrow little seatbelt one like it was in that video, or you can have a nice big T-pod one. But in general, you want it to be centered over the trochanters. And that's important because you can actually, especially with these big T-pod ones, they're kind of a lot, higher, wider, whatever you want to think about it, than they need to be, truthfully, because you can do it with a seatbelt type of thing or a sheet. But what you can do is if someone needs to go to IR with one of those T-pods on, you got this whole area, you can cut the inferior part of the binder away, and you're still fine. They can get access that way. Someone can go to the OR and have an abdominal or thoracic procedure done, and that binder can actually stay on if it needs to. You can just maybe trim the upper part of it down. It kind of just depends on what the needs of the patient are. But by centering over the trochanters, you're not only mechanically optimizing the function of the binder, you're also making it easier to take care of everything else wrong with the patient. Yeah. Yeah, good question. I wondered if that might come up. There's a facility in Denver Health, that became kind of the international leaders in advocating for pelvic packing, pre-peritoneal packing at one point. They don't do it as much anymore. So it's a really useful adjunct if someone cannot have bleeding controlled any other way. I think that in general now, when you look at trauma centers around the country and mostly around the world, we're biasing way more towards closed means or percutaneous means of bleeding control versus the packing. But if someone has a Reboa placed and then they're going to the OR, they're probably going to have packing placed, maybe in their abdomen in addition to the pelvic area as well. And it can be a useful adjunct. The primary problem that we're seeing is there's a significantly higher risk of infection when people get fixed surgically if they've had a bunch of sponges sitting inside their pelvis for a while. And so unless it's really necessary, generally speaking, most places are not rushing to do that. Yeah, right there.
Concerns about placement of Foley catheter.
Yeah, that's a great question. And actually our protocol kind of touches on that a little bit. The question was about placement of a Foley catheter in someone with pelvic trauma. So someone can have a torn urethra, right, or something like that. That's absolutely the case. And so generally speaking, we're going to try to put a Foley in these people, and if it passes easily and you get urine back, well, then I think we know we're in good shape. If you can't pass a Foley, then the right move is to not keep on trying to shove it into somewhere you don't even know where it's going, right? So you can get a retrograde urethrogram, and that can be done under X-ray. And I wouldn't be the one personally who would do that, so I guess I don't have all the details on exactly how it works, but that would be the test to do, is to get a retrograde urethrogram, or just look at the CAT scan, figure out a way to kind of figure this out, and then know if there's a problem. And so generally speaking, if someone has a problem like that where a catheter can't be placed, a suprapubic catheter will need to be placed, surgically.
But that would all be done.
Say that again. I'm sorry.
That would all be done.
Yeah, that wouldn't be. That would come later. But yeah, but it's an important thing to be aware of, because you don't want to put the catheter in and then it ends up running up to the diaphragm because you've shoved it in so far and it's not going to the bladder. Yeah, please.
About compressing with fractures, and this showed a picture with so much vasculature of parts. Not a concern. Better for the patient to just go ahead and close that space than to be concerned about something like if you have a femur fracture, you're worried about pulling apart rather than.
Sure. Yeah, and that's a great question, and that's come up before. I think it's a really common concern, right? Is that, well, we don't know what's going on. What if we make something worse? And so the question was about, is there a concern about maybe hurting things? You put a binder on. Is there a concern we have to think about these other things? And the reality is that when you look at the data on this, or even people's clinical experience, it is very, very difficult to make something worse by putting on a binder, at least if you put it on correctly. If you displace the femur fracture more, oh well. It'll probably be a bit more painful for the patient, but they're not going to die from that, right? Whereas they will die from an open book pelvis that's not closed down, right? Even a lateral compression pelvic injury where legitimately, but the binder will actually displace the fracture worse. It will actually shove the pelvis inward where it's not supposed to be. That's also been shown to actually be pretty safe. I mean, we don't necessarily leave the binder on forever like that, but you're not going to really be realistically at risk of causing a major damage to anything on the inside by putting on a binder. So generally speaking, what I always advocate for is it's far better to put, in almost all cases, it's far better to put one on, not knowing exactly whether or not you need it, than to not put it on and have the patient die. Yeah.
Most agencies have pelvic bindings, but some don't. You're talking about sheets. If you take a sheet and you cut, like, instead of having 2 pieces to tie, you cut them and you have 4 and you tie them diagonally. Do you have any familiarity with that?
It probably wouldn't work very well, I would think. So the pelvis it's like a ring, right? It's like a big donut, and you want to have that big circumferential hug. You know, the question was about whether or not you can use a kind of a combination of sheets as opposed to just one sheet or something like that. So you really want to have that circle, that ring, right, that kind of rings around the pelvis. And so that's why it's so helpful. And actually, it's a good point. You know, binders and or sheets are actually way more effective at closing down pelvic volume than an X-fix is in a lot of cases, because an X-fix only controls the front half of the pelvis, whereas the sheet wraps circumferentially around it and closes the back as well.
Dr. Gross, will you talk just a little bit about when we put on pelvic binders, maybe we leave them on for a little while, and the risk benefit of using a pelvic binder for 24 to 48 hours?
Sure, yeah, absolutely. And it's a great question, and it comes up because with anything on the body, you know, we think about, are we going to cause pressure sores or anything along those lines? And that's an important consideration. Basically, the pelvic binder can be thought of as a splint. And if someone has a dislocated ankle and we put a splint on their ankle, we don't take the splint off every day to check to make sure the skin's okay. We usually just kind of leave it on. Now, the pelvic binder has a lot more force on it, and it can, if it's left on for an extended period of time, it can cause skin issues, typically nothing that's full thickness or anything overly dangerous. Generally speaking, when the binder goes on, we start to think about a plan to get the patient into the operating room to get things fixed. But sometimes there may be situations, either logistically or medically, clinically, where the patient can't go to surgery, you know, within 24 hours. And leaving that binder on is the right thing to do. We don't just want to ignore it, right? And kind of what I was taught by my mentors is you manage it like you manage anything else. You kind of check the margins of it. You know, there can be nursing skin checks periodically and check on that stuff. And of course, we want to make plans to get the binder off, but it would be potentially very dangerous to take the binder off before there's something else ready to go. So in other words, usually the binder, when it comes off, is when we're in the operating room, and then we have something else ready to go. Because like that case that I showed, his pelvis was all closed down. I took off his binder, and I was just curious, like, how unstable was it really? Because again, we had only had that initial AP pelvis X-ray to show me, and it was horrifying how much it opened up. And so, like, yeah, it can be a very dangerous thing to take it off too soon.
Can you still turn patients when they have a binder?
Yeah, the question is about turning the patient, and actually that actually makes it a lot safer to turn them, because, I mean, you kind of need to. I mean, to take care of a patient and kind of check their skin or do, you know, kind of hygiene for the patient's backside. You know, when that binder is on, it's really helping to splint everything really, really well, and so they can be rolled. I mean, again, you don't want to necessarily do it rapidly over and over again, but yeah, it's very, very, by comparison, much safer to roll the patient once the binder's in place. Yes. Yeah.
For your patients that you've decided are not going to require surgical intervention, but are on the floor, and they have a lot of pain when they move, do you ever recommend a binder
The question was, would I recommend some kind of binder situation for someone who's non-surgical, but still having pain when walking? I don't know that a binder would necessarily be helpful. I suppose that some kind of support, maybe for coughing, like maybe that would be helpful. But typically, if someone has a stable pelvis, it means that it's truly stable, where it's not really experiencing any kind of major displacement. And in particular, if someone's pelvis is having any element of opening up while they're moving, they need to be fixed. So mechanically speaking, I guess I'm not even aware that anyone's ever really tried to throw like some kind of binder construct on someone who's non-surgical and just kind of have it lightly there for support. It might be useful, but I'd probably doing the whole, go over the trocaners and yank on it and really tighten it down. I mean, that's not like the idea of someone's good time, like as a patient, that they're not going to feel like really great with this tourniquet around their hips. But I mean, I suppose that it wouldn't really hurt, right? If someone has a stable pelvis and they want to have some additional support there, and they get some other kind of brace construct on there, it would be fine. It would be safe to do for sure. Yeah.
Okay, thanks,
Cool.
Dr. Gross.
Thanks, everyone.